So there are a couple of things. The title said to talk about the new institute, the new building, our new Southern Alberta Institute of Urology, and I'm happy to do that, answer questions relating to it. But there were three things that I thought I would briefly mention tonight to you. The first one is probably our newest program there that I suspect none of you, or sorry, most of you here are not aware of. We have what we call Rapid Access 1, which is where a patient is seen by their GP, there's some question or concern relating to the possibility of the patient having prostate cancer. So we've established a quick pathway to get the patient from the GP in to be seen by a urologist. Before we started this, and it must be now 4 or 5 years ago that we started it, before we started it, the wait time from concern to a diagnosis was 95 days. And that wasn't measured by us, that was measured by the business school at the University of Alberta in Edmonton. So we felt that that was not really good enough. And then we established this rapid access clinic. And what it is when a GP refers a patient in to my office, to anybody's office, we look at the referral and decide if there is a concern, and if there is, we will then book an appointment at the Rapid Access 1 clinic. And that's a clinic that runs 2-3 times a week in the prostate centre. Each day a different urologist staffs it, sees all the patients, even though they're not necessarily referred to that particular urologist, but gets the patient into the system, gets things moving. If there's a need for a biopsy, gets the biopsy set up, gets things moving forwards. Over the years, our target was to have that first visit within 2 weeks. For the first year, we managed it within about 1 week. Last year, we slipped a little bit. In fact, at one point, it got so far as 3 weeks. We're right now back down to 7 days. We have many people who have a referral now, and we phone them back and give them an appointment, and they say, oh, that's too soon, I'm not ready. So we'll never get to the point where we'll have somebody in the next day because they won't come. But we're back to about 7 days now from referral by the GP to being seen by a urologist. And the biopsy time, from the time once we see that patient until we can get a biopsy, runs in the region of 2 weeks. In the fall last year, there were some changes made in how the laboratory was run and how the pathologists were organized, and it caused it to get long. It caused it to get very long. There was a major row among ourselves and the people running the lab, and that's been sorted out. And now that time is between 1 and 2 weeks to get the biopsy, and about a week to 10 days to get the result of the biopsy. So the whole thing is now in the order of 20 to 25 days from the time your GP sees you until we've got an answer. So that's called phase 1. Phase 2 was then we make a diagnosis, and as many of you know, all of you know, there's no clear, simple one answer as to how's the best way to treat this problem. Do we need to treat it? And if we do need to treat it, what are we going to do? So what we try to do is we try to educate the patient to the point where the patient can make an informed decision. Because we know that we have our own inbuilt biases. I'm a surgeon, so I naturally think that surgery is a great way to go. A radiation therapist naturally knows that radiation therapy is a good way to go. And we should feel that way about the treatments that we use. If we don't feel that way about those treatments, we shouldn't be using those treatments. So and it's very easy for us when we're talking to a newly diagnosed patient who's usually very vulnerable at that time, it's very easy for us to influence the patient. And it would be easy for us to allow our bias to come through and influence the decisions of the patient. And we don't want to do that. Surprising as it may sound, we really don't want to do that. We want to lay out the smorgasbord and then try to help the patient to reach a decision. There are times when it's pretty clear-cut what's the best way to go. Younger guys, we want to treat in a particular way. Older men, we may want to treat in a different way. We don't want to do a radical prostatectomy on a 75-year-old. There are easier ways of killing him. We want to do a radical prostatectomy on a 45-year-old, though. So we then opened up this session, we call it the Educational Forum, or Phase 2 of our Rapid Access, where we run these sessions on a Wednesday evening. We have a radiation therapist, a medical oncologist, and a urologist. We have a set of slides that we, as all of the docs in town who treat prostate cancer, have agreed on and put together, so they're not controversial. We present the slides, talk about them, do a question and answer session, give the patients the slides going home to try and get them better informed. So then the next leg really of that pathway was, what do we do once we've actually treated the patient? And today, we don't look after our patients as well as we used to. We simply cannot do it. The way I practice has changed radically in the last 40 years. Many years ago, I would treat somebody, they would have my home phone number, they could phone me at home at any time of the day or night, and they did, let me tell you. And it was much more of a one-on-one relationship and follow-up and care. We simply, physically, mentally, psychologically cannot do it today. The volume that we carry is so great, we're just not able to do it. So we felt that there was a gap in how we were managing somebody. Once they had their treatment and went home, they were on their own, a lot. You know, we said, yeah, we'll see you back in the office in 6 weeks, but don't try to get in touch with me in the meantime. Yeah, we would say try to get in touch with me, but I have trouble getting through to my office. How does somebody else out there manage? And so what we've done is we've set up Phase 3. And Phase 3 is one of our nurses currently, and it will be 2, who literally becomes mum. So if you go in and have your treatment, most of the time before you leave the hospital, Louise Thompson, who's our nurse, will come and see you, talk to you in the ward, give you her business card with the contact information on it, and we'll arrange to see you and handle any issues and concerns. So if you have a worry, you have a problem, you pick up the phone, you talk to Louise, you will get to her much more easily than you'll get to me or one of my colleagues. She can troubleshoot most of the problems. If she can't, she knows where to find us and grab us by the scruff of the neck and say, look, Joe Smith's got a problem, you need to deal with it, and we deal with it. So it was to try and provide better, more comprehensive post-operative care. And so we've piloted that last May. We started it in May with just 5 of us urologists. And we compared how those people did, the people for the next 6 months. We compared that with, we had gathered records on the year 2009, how people had done. And we have reduced the visits to the emergency department from 30% to 8%, and the readmission rate from 4% to 2%. And we have much happier patients as a result of it. So that's our Phase 3 of the rapid access, and it's something that I particularly am, and we all are very proud of and very pleased with. 2 other things I want to talk to you about. One is PSA. Now, I know I'm preaching to the converted here, and there's been an argument going on for years about PSA. Is it good? Is it bad? And the ivory tower academics who don't treat prostate cancer, who rarely look a patient in the eye, have for many years been opposed to PSA on the basis that there was no evidence to show that doing PSA saved lives. And it's a reasonable argument. We know that there are many screening things that can be done in medicine that actually don't help. There was a time when there was a screening for lung, you get a chest x-ray looking for lung cancer. Waste of time, a waste of money. It doesn't matter. You get it, you got a problem. The same applies to stomach cancer. On the other side of the coin, we know that screening for cervical cancer in women doing Pap tests really save lives. So these people's argument was there's no evidence to show that PSA saved lives. Now, guys like myself who are on the ground dealing with people, we knew that PSA was saving lives because, and you may have heard me say this before, in my lifetime in urology, prostate cancer has gone from a disease that was essentially a hopeless disease when I was a kid to a disease that today many people are saying, gosh, are we over-treating it because we're so good at finding it. when I was starting out, 90% of men who were diagnosed with prostate cancer were too far gone in the disease for us to cure them. 90%. Again, when I go back 30 years, when we would make the diagnosis first off, 40% of men had bony secondaries, bony metastases, hot bone scan, 40%. In the last 10 to 15 years, that has totally changed around. Today, about 10% of men, when we diagnose them, their cancer is too far gone to cure. But 90% of guys, we can do something with curative intent. At the time of diagnosis, years ago, 40% had a positive bone scan. Today, that is 4%. Tenfold reduction. There is only one thing that has happened in my lifetime to bring about that change, and that's PSA. There have been two big studies done. I just put this up as a starting point because today we use age-related numbers because as you know, we get older, our prostates get bigger. The bigger our prostate, the more PSA it produces. PSA is a blunt weapon. It's not a cancer-specific marker. It just happens to help us find cancer, and we will in time come up with a better marker, but by gum, it's the best thing we've got in any aspect of medicine. And we've refined it by using age-related, so the younger the man, the lower the reading. When I was 49, my PSA was 3.1, and I remember going home, and my wife was at home. She had heard the result before me. She met me on the deck and said, "It's great, your PSA is normal, it's less than 4. I said, "What is it?" She said, 3.1. I said, "I have cancer." And I knew I had cancer, and I did have cancer. And my reading was way down. At that time, we didn't have age-related numbers. Today we do. And I'm very aggressive in men over the age of 40 and under the age of 50. I'm very aggressive in chasing those guys because those are really the guys that we're going to make a heck of a difference to if we find them. Sad to say, if you're 70, 75 and we find your cancer, I'm as likely to cause you trouble by treating you as the cancer is. But if you're 43 or 48 or 52 or 54, we should do something because it'll kill you. And so there have been, it's working. This is a graph from one of the really landmark studies in prostate cancer management in the world. And this comes out of Scandinavia. We refer to it all the time as the Scandinavian study. And it is a comparison of men who were diagnosed with prostate cancer. Half of them were treated with radical prostatectomy. Half of them were treated with observation. And you can see the two lines. The higher the line, the greater the death rate. And the untreated line is considerably higher than the treated line. In actual fact, there's a 50% difference out here between the two groups. In other words, the people who were treated have a 50% lower mortality rate from prostate cancer compared to the people who were not treated. So this study answered one of the big questions. Are we over-treating patients? We're saving lives by treating patients. There are patients that we are over-treating because as you can see, this doesn't even go to 100%. So out of 10 years, this is about 15, at 15 years, it's 20% is the rate, the mortality rate. So if you're diagnosed today, nothing is done for 15 years, the chances are 20% of those men are going to be dead within 15 years because of prostate cancer. More of them are going to be dead from other things. But this really clearly made the case that, yes, we should be treating patients. We have to refine who do we choose to treat, how do we select the people we treat, and that's our next step. But the first step, I feel, is to diagnose the disease. And part of that is awareness, getting younger men to come and be tested. The Man Van is an example of that, getting them to go and get their PSA done, letting us see them, and making the diagnosis. Then the next big hurdle is, what do we do? How do we best refine how we treat the patient, who we treat, how aggressively we need to do it? And that's the next step in the road. So there were two big screening studies done, and if I'm being repetitive to you, I'm sorry, but there were two very big screening studies done to assess whether using PSA as a screening test was going to save lives. And there was one in North America, it's called a BLCO, breast, lung, colon and ovary trial, 76,000 men, and the European randomized trial, 82,000 men. The BLCO American study at 10 years showed no difference in prostate cancer specific death between the two arms. So, you know, you say, oh shoot, it shows PSA is no good. But when you look at their study, it was a crappy study. Because in the studied arm, the guys who were not meant to be having PSA tests, 52% of them were having PSA tests on the quiet. In the arm that was being meant to be screened, 82% of them were having their PSA done, not 100%. So the difference between the two arms was about 30%. You're not going to, in these numbers, you're not going to see a difference at 10 years. You probably will see a difference at 20 years, but you're not going to see a difference at 10 years. When they went back and looked at their data and looked at men coming into the trial who had had 2 PSAs before they entered the trial and compared them to men coming into the trial who never had a PSA done, there was a 27% difference in mortality rate, virtually identical to the European study. But most of us dismiss this study as a poor study, and you cannot draw any solid conclusions from it. The European study was a very good study. Every study we do has imperfections, and the European study does. But in Europe, if you were not in the study arm, you didn't get a PSA. You just didn't get a PSA, period. Whereas in the study arm, you did get a PSA. Now, in their study, around about 10 to 12% of people in each arm didn't comply properly with the requirements of the study. But that's an acceptable contamination rate, is the term we use. And they found, the BLCO, as I said, the European study found at 9 years of follow-up a 20% reduction in mortality from prostate cancer. When they cleared their data and looked at those who were tested versus those who were not tested, therefore excluding the people who did not comply with the study requirements, they found actually at 9 years a 31% difference in prostate cancer specific mortality. They will later this year publish their 11-year results, and the expectation is that this difference is going to be somewhere in the region of 50% between the two arms. So this study puts to bed the argument about does PSA save lives? It saves lives, make no mistake about it. Where we have to go, as I said, is to now decide, okay, we have a diagnosis of prostate cancer on this man. What do we do? What's the best way to treat him? Do we need to treat him? And what we really need, and what many, many places are looking at, and we are just starting to do it now here ourselves in the lab, is to look for gene markers or gene mutations or some sort of a protein, we call them biomarkers, that we could measure maybe in the tissue, maybe in the urine, maybe in the blood of a patient, and that this biomarker can help us refine. We could have 2 men with Gleason 7, and one might have this biomarker and the other one doesn't. And we know the guy who's got the biomarker has got a bad disease, and we've got to be after it. But we know the guy who doesn't have the biomarker doesn't have a bad disease, and we can watch him. That's what we need next in our catalogue of weapons, or in our arsenal of weapons. A term that's used today oftentimes to assess the benefit of any intervention that we use is number needed to treat and number needed to test. So in other words, the number of people you need to treat to save a life, or the number of people you need to test to save a life. And at 9 years in the European study, the number needed to test was 1,410. The number needed to treat, 1 in 48. However, if you follow it out to 12 years, the number needed to test is 500, and the number needed to treat is 1 in 18. How does that compare to other diseases? Breast cancer is about 1 in 100, number needed to treat. 1 in 100. Prostate, at 12 years, is about 1 in 18. But we don't hear that. You don't hear that in the lay press. You don't hear that publicized. You don't hear that talked about. because we lost that public relations battle many years ago. So that's PSA. This is the graph from the European curve. And you can see as time goes, the European study, these lines are diverging. Always when you get out to the end of these numbers, the lines go all over the place. You can't, because from a statistical point of view, you can't put any weight on them. You have to cut them off at about here. And their new results, their new study will come out to here. And the lines just continue to diverge as time goes by. So I did actually spoke about this last week to a group of GPs, and that this was my take-home message: do PSA testing. And this is still a battle that we're fighting with our own general practitioners, because 15 years ago they were told don't do PSA testing. And once that message sinks into people, it's very difficult to turn it around and change it. It's an uphill struggle. We're winning the battle, but we haven't won it. We've still a long way to go. So that's the second thing I wanted to talk about. And the third one is, I've been keeping a database here since 1994 of men who have a radical prostatectomy. And patients will often want to know, how am I going to do? What are the results like here? And in many places in the world that treat prostate cancer, the statistics that will be quoted to you are the best statistics from the best center in the world. That means nothing if you're not in the best center in the world. What matters is, what are the statistics like here, where you're going to be treated? Here. How do we compare? So initially, when I started that database, it was to look at how we were doing in the operating room, post-operative complications, continence, potency, how the people were doing in the short term. But I always wanted to follow up over a long period of time and see how people do. And the final arbiter of how our treatment is working is, are you alive or dead from the disease? So what I've just started to do, and this is early and these are not set in stone, is to look at mortality rate in men who've had a radical prostatectomy. And it's 15-year data on men who've had a radical prostatectomy. Now, some of them only had a radical prostatectomy in the last few years, so they're early in the sequence, but some of them were back in 1994. And what we look at when we're looking at these sort of things, we look at two things. We look at overall survival. Now, overall survival means you're still alive, irrespective of what the other men died from. Because it's not just prostate cancer that can kill you, there are other things that can kill you. And here's our overall survival curve. And you can see, at 15 years after treatment, 65% of the men who've had a radical prostatectomy in this city are still alive. For whatever reason, they're still alive. If we look at disease-specific survival, and this is your chances of dying from prostate cancer. You can still get hit by a bus, shot by a jealous lover, but your chances of dying from prostate cancer, and if you take a look at this, 95%. These numbers are as good as anywhere on the planet, and perhaps a little bit better than many of the big name centers in North America. Just fortuitously, and it was in your magazine, the digital, I forget this, but your magazine, and it was alluded to in the magazine. There is a paper published about a month ago, a fellow by the name of Egener, out of the States. It's e-published at the moment. It's going to be in the Journal of Urology in March. And they looked at they looked at 4 hospitals in the States and compared them to another hospital in the States and have published their data. And they were actually looking at 15-year survival. So one group was Memorial Sloan Kettering, which is in New York, the Cleveland Clinic in Cleveland, Baylor in Texas, and I can't remember what the 4th one was. But these would be, 4 of the top 10 cancer treatment centers in America. They had 11,500 cases, and they compared their 11,500 cases with 12,000 cases from Johns Hopkins, which is where Patrick Walsh lives, and would be considered perhaps to be the premier prostate cancer treatment center in North America. And then I put up our numbers beside them, and I don't know that I have a pointer. But if you look across the top, the numbers of cases, so they have 11,500 in the group of 4 hospitals, 12,000 in Hopkins, and 2,500 here in Calgary. Small, but If we had 4 other hospitals, we'd bring it up to 10,000. The median age, that you can see, so that's not the average age, this is the most common age. 60 in the Sloan-Kettering group, 58 in the Hopkins group, and the Hopkins people tend to treat young people, and ours was 61. Median PSA coming in, very similar. Ours is a little bit higher, as I would have expected, but 6.0 in the Sloan-Kettering group, 5.9 in the Hopkins group, 6.4 in our group. That is a significant difference, actually. Ours are higher because us Canadians tend to come a bit later than the Americans do to get checked. The median follow-up, 56 months for the Sloan-Kettering group, 96 months for the Hopkins group, 86 months for ours. But all of us have people out at 15, 16, 17 years. The Hopkins group has 1,600 people between 15 and 20 years. We don't. We have about 120 out there. The Gleason score, which is a very important thing because it helps us to check and see, are we comparing apples to apples? And you can see in the Sloan-Kettering group, about 1/3 of their men had Gleason 6, whereas in our group and in the Hopkins group, 2/3 of men had a Gleason 6. And then the Sloan-Kettering group had half of their patients had Gleason 7, whereas in the other 2 groups, ours and Johns Hopkins, it's at 1/3. And then the high risk, Gleason 8 or higher, all of us were 5 and 6%. And the reason for that is that, generally speaking, radical prostatectomy is recommended for low-grade or intermediate-grade disease. We do it for high-risk disease, but we're much more circumspect and cautious in doing it. And happily, the number of men coming in with high-risk disease is relatively small too. Positive margins is a thing that we as surgeons use to check on how we're doing surgically. In other words, are there cancer cells at the edge? And the Sloan-Kettering group, it was 23%, and the guy who's considered to be the best surgeon in the planet is there, a fellow by the name of Scardino, and their number is 23%. The Hopkins number is the anomaly here. It's 13%. Most centers in the world would say, I don't think you can get 13%, because every place on the planet is publishing numbers in the order of 20 to 25, 26, 27%. And our number was 24%, same as the Sloan-Kettering number. We looked then at prostate cancer specific mortality, second last column there. 1.4% in the Sloan-Kettering group, 1.6% in the Hopkins group, 1.36% in our group. Same numbers. And then death from other causes, 5% in Sloan-Kettering, 4% in the Hopkins, and ours is 8%, and that's because we had an older group of patients, and you would expect that. So how are we doing with regards to surgery for prostate cancer in Calgary compared to the best places in the States? We're doing exactly the same job. What's interesting to note there is if you look at this prostate cancer specific mortality and then look at the one below it, the other mortality, the risk of dying from something else is 6 times higher than it is of dying from prostate cancer if you treat somebody. And so that's all I have to present to you, and if you have any questions, I'm more than happy to answer them.
In the new rapid treatment process, do the patients have a choice of which doctor they might, a specific doctor, or is the doctor just randomly assigned to a...
No. The patient, and in setting it up, we were very meticulous in this. One of the things we want to maintain is the relationship between a GP and a specialist, because that's very important. So the referral is not to the rapid access clinic. The referral is to the normal urologist that GP deals with. So let's say the referral comes to me. I will look at the referral and say, okay, this patient should go to the rapid access clinic. We book the next available appointment in the rapid access clinic. It doesn't matter which urologist is there that day. It could be me, but it could be any one of my colleagues who would see the patient day one, make a decision as to whether this is serious, do we need to do a biopsy or not. If there is a need to do a biopsy, initiate a biopsy, and then I see the patient with the result. So the patient is then comes back to the original referred urologist and followed by that urologist. But the day you're in there, it's potluck as to who's there. But we like to think we're all equally competent or incompetent.
Dr. Donnelly, I was a patient of yours when you undertook the clinical trial. How many years ago was that?
Well, the first one started in 94. The second one, the randomized trial comparing with radiation, started in 98.
98, okay. When is one going to receive the results of the second one?
I published that, I presented that 4 years ago up in the foothills at one of the meetings. And I've presented it around the world, and it was published in the journal called Cancer. I can't remember whether it was January of 2009 or January of 2010. I think it's in the library, because I gave it to Linda.
I don't think it was that widely advertised that the results were published. I never heard them. You say, where can one get the results?
They're published in a journal called Cancer, and mine is the first name on it. So if you look up, if you go on PubMed, put in my name, Bryan Donnelly, you can put in randomized, put in the word, you put in a few keywords, prostate cancer randomized, it'll come up. But it also would be available, I think, through the resource centre. Yeah. And the results were good. You're still alive.
I was going to say, you did a cystoscopy, whatever it's called, on me about 15 years ago, and you did a good job. It's still working real good. Thanks a lot.
You're welcome.
Oh, yeah.
We get home a lot of media, television, and newspapers and things like that regarding free radicals. We're supposed to get rid of free radicals. And yet if you have radiation, they want you to have free radicals to attack the cancer cells. How do you treat the balance on that?
Well, I know where the radiation is concerned in treating cancer. What they're trying to do is actually disrupt the normal function of DNA at the chromosome level, so that the DNA is not able to function properly to form a new cell. One of the reasons why radiation takes a while to show its good effects is that the cells don't turn over very quickly. So it takes quite a while for the PSA to come down, because the radiation only has its impact at a certain point in the cell division. As regards other free radicals, I really don't know. I'm afraid I don't know a whole lot about it. We do get bombarded with them all the time from any source. I mean, you get up in an airplane, you're going to get bombarded with them. You probably get more radiation in an airplane flight than you do in a chest X-ray, but it doesn't stop people flying. I can't give you any more of an answer than that. I'm sorry.
Donnelly, you treated me in '99, and so before that I was having a once a week a good migraine, and ever since I had no more problem. How does that affect?
I missed you. Once a week you were having
A migraine.
Maybe we could get together and bottle it and sell it, because we'll make a fortune. I don't know. I really don't know.
I never had any more problems with it.
Wow. Well, I'm glad, yeah. I wish I could take credit for it, but I don't think I can.
Could it be because of the hormones you get beforehand, before the treatment?
Yeah, but when did your migraines begin?
Towards the weekend? I mean, during the week or?
No. Had you migraines before you went on the hormones?
Yeah. Oh, yours before.
I don't know. I don't think so. I don't know. I don't know. I'm not aware of any link. But that's good. I'm glad for you.
I wonder if you could tell us why we don't hear as much about cryotherapy anymore.
I don't know. I'm often actually asked that question, because really in Canada, Edmonton and Calgary are the two places that are doing it. London used to do it. I don't even know if they're doing it anymore, because I think he's moved on to investigate HIFU. But he may still be doing it, Joe Chin, I'm not sure. I really do not know the reason for that. When cryo started in the States again in the early 90s, the manufacturers of the equipment thought that they had found a new way to make an awful lot of money. So they encouraged a lot of urologists to do cryosurgery without a proper training and without proper knowledge of what they were doing. And certainly in the early 90s there were many serious complications. And it's a bit like when GPs were told 15 years ago not to do a PSA. When a negative perception gets into people's heads in medicine, it is pretty hard to root it out. I've been called a quack by some of my colleagues because they don't understand or didn't understand cryosurgery. And we do not here at the moment, we do not have a residency training program. I think if we had a residency training program, then new urologists as they're being trained would be exposed to and taught how to do cryosurgery, and then when they would move someplace else, they would start a cryo program. But we don't have that. We don't do that here. So unless I move to other places, it's hard to teach people. But I am puzzled myself at why, because it's a very good treatment, it's very well tolerated, it's particularly good for people who have health issues that prevent other forms of treatment. It's the only curative treatment option for men who've had radiation and have a recurrence. So I would feel it should be all over the place, but it isn't. Yet I get referrals from Western Canada to treat particularly radiation failures. But I don't know, and it's always been a mystery to me. And I'm not going to go out beating the bushes, and I prefer my own bed now to a hotel bed. So I used to travel a lot and speak a lot about it. I don't anymore. I'm tired.
I just wondered because I was treated the word I was frozen. That's what in 1998, July 1998, and I'm still here.
Yeah, no, there's a lot of men.
That's not bad.
Yeah, no, there's
and my PSA has never gone over. Once it went up to 0.3 or some kind of thing. Just yeah. It's been 0.02 or 0.3 or since then.
Yeah, and it's just, as I often say to people though, it's just another way of skinning a cat. It's another treatment option that's there to treat prostate cancer. Like all of the other treatment options, it has the potential to fail. Like all the other treatments, it has its own group of side effects, but it also is at least equally successful, and in some cases more successful than other treatments.
Well, Cheryl Scott was the one that told me about it, and you folks talked to me about it, so you convinced me.
Cheryl convinced me.
Cheryl was a treasure.
In many kinds of surgery, there's been a rapid movement towards laparoscopy for the last 20 years. Mm-hmm. Is that happening to the same extent for prostate? Yeah, it's actually gone another step farther. It went from open to laparoscopic and now to robotic, or what's called robotic assisted laparoscopic. We have one robot here, expensive piece of equipment. We really hope that it will show better results. In particular, we hope it will show better results for potency, erections, and for continence. As yet, it doesn't. Around the world, I mean, there are many centres that have had it for 4 or 5 years now, and as yet, there's no clear evidence to say it is superior to open surgery. It is superior to laparoscopic surgery. In fact, now nobody does laparoscopic here. They will only do robotic-assisted laparoscopic or open. The one place where there is a clear benefit to the robotic is in what we call a bladder neck contracture, which is it's a 7% risk after open surgery. It's about a 1% risk after the robotic. But I do think that with time, I do hope that with time, it will improve the ability to preserve the nerves that let us have an erection. Well, sadly, it's not doing it yet. We do a pretty good job open, actually.
Is it too soon for you to assess the success of locating all of the prostate treatment in one center? How is that working?
It is. Well, all of the treatment is not localized because radiation therapy is still done up at the cancer board, and always will be, because the bunkers are underground and those machines are used for more than just prostate. What we are trying to do, and what I really want to do, is to get the radiation therapists and the medical oncologists at the Tom Baker to come down to our new building and run clinics there, and they will. It's a marriage of two different cultures, and it's difficult. But we're making progress in that direction. The will to do it is there. The systems are different. So their computer system is totally different. Their dictation system, their lab tracking system is totally different. How they're paid is totally different. Their nurses, they have a nurse each, we don't. They don't have a secretary, we do. So these are things we have to work out, but that is something that will happen, and to me that is really a huge step forward, because it lets us cross-consult much more readily, get many opinions on a difficult case much more readily, but it also fosters a greater contribution to clinical trials and studies, because every patient that we treat should be in a study. That's not true though. But it's more likely to happen when they come down, because they would, we would work together cooperatively to make that happen. Among the urologists ourselves, we are finding, which is something that I thought would happen, that we are increasingly subspecializing. So, we've got guys who are really good at treating your kidney stones. We probably have the best guy in North America for treating your kidney stones here, actually. We also have guys who have a lot now of expertise with the robot, some of whom have great expertise in doing kidney surgery with the robot. We now have established what's called the Alberta Bladder Centre, and it's for bladder problems, leakage problems for men and women. And we have 2 urologists who are dedicated to that. We need them actually to recruit in a 3rd one. So these sub-areas are being increasingly focused on. I do cryo for prostate. I also do cryo for kidney cancer, the only place in Canada that does it. But because I'm in this group, I can do that, because if they've got a suitable case, they refer it to me, and I do the case. So being in a group like that greatly facilitates our ability to subspecialize. What can be lost in that is the treatment of the mundane urological problems. I just do this, I don't look at that. And that can be a problem, that we have to be careful that we don't lose that as well. But we as a group of urologists love the change that has taken place. Oh, we are. We are way more efficient. And I mean, an example is, and this was not terribly long ago, one of the guys was in the lithotripter breaking stones, and a patient of his who had been referred to him came into the emergency department. The emerg-doc phoned him, and they had a conversation, and he said, yeah, you know what, let's get a CAT scan done, and we'll get a CAT scan. So he's sitting there doing stones, the patient gets a CAT scan, he can look at the picture straight away. At his lunch break, he goes across to the office with the patient, sorts everything out, and the guy has surgery about a week or 10 days later for his kidney tumor. And it does, we don't have to jump into, when I get into work now, I park my car, and I don't see my car until I go home. When we were elsewhere, I was in my car 4 times a day. And that's a desperately inefficient use of a resource. But we're on site now, the wards are there, the operating rooms are there, all of our treatment facilities are there. So it's a huge efficiency for us. The other hospitals don't like it, because we're all there.
What's the oldest patient you ever did cryosurgery?
Sorry?
What's the oldest patient you ever did cryosurgery?
I did an 82-year-old man, must be at least 10 years ago. And I oftentimes, when I look at the statistics, I would say to myself, what in the name of God was I thinking when I did that case? He was going to work every day when I did him. He's not working anymore, but he's playing bridge 5 days a week in the ranchlands, and doing fine. He's now 92. So the oldest I've treated was 82. I don't know that I'll treat many older, because I think that I may not need to treat somebody that much older. There are other ways that we can treat people.
You mentioned that the person who was doing cryo at London has gone into do research on HIFU. Is there any more solid evidence on HIFU than there was a few years ago?
Sadly, no. I've had lots of very lucrative financial inducements to do HIFU here and have consistently refused. And the reason that I refuse is I think it is a great technology, but it's got a long way to go to be ready for prime time. What it literally does is it cooks a tiny little strip of tissue. So to treat somebody, you have to cook a piece here, you have to cook the piece beside it, the piece beside it, the piece beside it, the piece above, the piece below. So the patient has to be dead steady, and the patient's prostate has to fit the beam, rather than the beam fits the prostate. When they get the technology to the point that you can make the beam fit the prostate, then I think it's a very interesting technology. It's been looked at in prostate, it's been looked at in kidney cancer, and in both areas the results are not great. They're not bad, but they're not great. There are better results out there using other technologies at the present time, and the other technologies are free. HIFU is 23 grand.
Your comparisons with Johns Hopkins and MSK were very interesting. About half of cancer patients, I suppose, maybe slightly less, will have radiation treatment at some stage in their lives. I was just wondering, how do we compare in Calgary in terms of the radiation equipment we have? I mean, we're a very wealthy place. Do we have cutting-edge radiation equipment which they might have in Johns Hopkins or MSK or even Sunnybrook?
Yeah.
Are we keeping up to date? Because we read every day in the press how stretched the system is and how short of money it is. Do you have a comment on that?
We do. The technology that they have here at the Tom Baker is as good as anywhere. We do not have what they have in Loma Linda. We don't have the proton beam. There's a lot of argument among radiation specialists as to how good or bad that is anyway. It's a $50,000 treatment. But no, we've got 3D conformal IMRT here. We've got brachytherapy here, and the brachytherapy here is, I would feel, is probably superior to the brachytherapy in a lot of places, because it's done, the treatment planning and dosimetry is done live. It's done right there and then when the procedure is being done. Whereas in many other centres, you come in ahead of time, you have your prostate measured, they do all the calculations, you come back a couple of weeks later, they do the brachytherapy. Our prostates are dynamic. They're not a box. They change, move constantly. So the advantage of doing it the way it's done here is it's live, it's done right now while it's there in front of them. They measure, they do their calculations, they do their dosimetry, they put the rods in. And the results are very good. They should be good, because it's low-grade disease generally that's treated, and any treatment that we use for low-grade disease should be very good. The data I just showed you on our results here, I'm looking at our Gleason 6 patients and how well they've done, and I'm saying to myself, they've done incredibly well. They've done so well that, yeah, you know what, maybe we could have left some of them alone for a Gleason 6. It's different when you get to at least in 7, 8, 9, but for at least in 6, it's not an aggressive disease. Have I answered you?
I have one other question. Are you taking any new patients?
No. Hang on. What have I not answered?
My question?
Yes.
Really about the equipment. I mean, I wondered whether, as a patient, how do you know whether you're going to be radiating with latest equipment or generation equipment? The latest machines, I understand, and they're not that recent, they're sort of image guided, which, as you say, the prostate moves and it follows it every day and so forth. Do we have that sort of equipment? And if we do, would it be rational? Do we have so little of it that maybe brain people need that and not prostate people? And prostate people have the 3D conformal. As someone who's about to have radiation, I'm interested in comments on that?
Yeah,
We've been told they've got old equipment they need replacing.
you know what? You can ask any one of us. When I get a new Mercedes, it's old the day after I would drive it out of the garage, and I couldn't tell you the age of their machinery. They know that. I don't deal with their machinery. I don't handle their machinery. But it is a discussion we frequently have with them. They tell us they have the same capability as 98% of the centers in North America. From the point of view of the dynamicism of your prostate, most of the time, I don't know, it depends on which radio, they will put little seeds around your prostate as markers for the boundaries. So each day that they target you, they use those targets for where they aim their beam. And so their focus on the prostate is very good. As to how new their stuff, you'll have to ask them that, you know, and see what they have to say. I couldn't tell you how old the machines are.
So in the interest of getting Dr. Donnelly to where he needs to go this evening, we'll take 2 more questions.
Doctor, for guys that are 70 and older, how often do you suggest the PSA test?
Is this somebody who's never been diagnosed?
Well, someone that doesn't have it.
Doesn't have prostate cancer.
Right.
Or doesn't
Annually.
No, doesn't have cancer. Has a prostate, but no.
Yeah, and annually, what we're actually feeling more and more and more of us feel that over the age of 75, if your prostate's normal to feel, if you have no symptoms, if your PSA has been normal up to then, don't do it anymore. Yeah. Because if at 80 we find something new, the chances of it killing you are pretty small. But the chances of somebody like me causing you trouble, they're not pretty small. You know, so you're better off out of my hands, actually. I hate to say that.
I wonder what you consider a 57-year-old with a PSA of 7. Would you consider their prostate possibly cancerous?
I would consider it possibly, but I also would consider it maybe very big.
The urologist that checked this chap, it's supposed to be my son, he said that he couldn't find any indication anywhere that it was swollen or had any part of the prostate that was appearing in trouble. And I just wondered if it's possible that you could have a PSA of 7 at 59 and be okay.
Yeah, it is possible. It is possible. A lot would depend. Is that a single reading? Is it a series of readings?
He did it digital.
Yeah. No, but that's one PSA result.
Oh, yeah.
Has he had more than one?
Oh, yes, he had it checked regularly.
You know, a number of that in that age group I would be concerned about, but a lot would depend on how the prostate itself felt, how the PSA has moved over time. And I don't know whether he's having a biopsy or not, but I would suspect that if it stays in that range.
He has to have a biopsy. In fact, I wonder about these biopsies. How come they do them after the fact? The protocol you'd think would be to do a bone scan on an older person before they do a needle biopsy. But gee, I came to a meeting here and I heard all these chaps getting up saying I'm 21 needle biopsies, all cancer. No, I think the protocol should be the opposite. In that age group, you do a bone scan and save the government money, and if it's gone into the bone, you don't do a biopsy.
Yeah, but we do know actually, we know that your bone scan is very unlikely to be positive if your PSA is less than 40. If it's over 20, we will in some instances do one. I know, but every rule in medicine has an exception.
I know.
But long since we opted to go the road of biopsy first and then doing bone scans in a limited number of patients. I would think that I do a bone scan today in a significant minority of patients. It's not often that I do a bone scan. I have to have some other reasons to make me do it.
Well, I'd rather have, if I have prostate cancer, I'd have the bone scan first to find out if it's gone into the bone, and then if it has gone into the bone, you won't have to do this off-needle biopsy.
Don't forget that today 96% of men who are diagnosed with prostate cancer have a normal bone scan. 4%.
Yeah, well, Doug didn't have one, he had a bad one.
Yeah, I know, and we have to sometimes balance these sorts of things.
But how about all those other chaps that were younger, that went through the bone scan, went through the prostate biopsy and found out that they had the cancer was all throughout the prostate. I mean, I don't know why, you don't do it the other way around. Have the bone scan first when they think that the cancer's in there.
Yeah, I actually don't, I wouldn't see a benefit myself to going that route.
I know, I've heard them say that this and that about it, but I'm just wondering. I'm keeping the saving government some money.
Well, we are conscious of that.
Well, thanks so much, everyone, for your questions. And